So hello, and thank you for joining us for our next session on day 2, the evolving field of radiation therapy for prostate cancer. My name is Nicole Abbott. I'm the Senior Coordinator, Patient Programs and Education here at ZERO Prostate Cancer. I'm really excited for you to hear from our esteemed featured speaker, Dr. Jonathan Leeman, you can see him, but he'll be joining us speaking shortly here. Dr. Leeman is an assistant professor of radiation oncology at Harvard Medical School and serves as director of MRI-guided and adaptive radiotherapy at the Dana-Farber Brigham Cancer Center in Boston, Massachusetts. Dr. Leeman is also a wonderful member of ZERO's Medical Advisory Board. So we're really glad to have him on board with our team. So thank you, Dr. Leeman, for joining us today. And it's my pleasure to hand it on over to you.
Wonderful. Thank you so much. And so I am Jonathan Leeman. I'm a radiation oncologist in Boston at the Dana-Farber Cancer Institute, Brigham and Women's Hospital. And I'm really thrilled to be here today to talk about the evolving field of radiotherapy for prostate cancer. As I'll try to describe today, radiation treatment for prostate cancer has changed substantially just in the last few years, and it's sometimes hard to keep pace with all of the new developments. And so I really want to try to keep things as up to date as possible for all of you and talk about the latest cutting edge research. So these are just a few of my disclosures about today's talk. And just a brief outline, I want to cover basically 3 topics. One is new advancements in radiation techniques, specifically stereotactic radiotherapy. Second is new advancements in radiation technology, and I'll focus on MRI-guided and something called adaptive radiotherapy. And then I want to spend the last part of the presentation talking about radiation therapy for people with metastatic prostate cancer, because this is an area where radiation is playing an increasingly important role. And throughout today's presentation, I'm going to try to focus on recently published and presented evidence, again, to bring to all of you the most recent research findings from our field. And so first, stereotactic radiotherapy. What is stereotactic radiotherapy? Or sometimes it's called SBRT, stereotactic body radiotherapy, or you may hear SABR is another form for it. And essentially, this is a condensed form of external beam radiation treatment. So instead of the radiation treatments that span several weeks, that could go on for 4 weeks, 6 weeks, even 9 or 10 weeks, this is a treatment that's done in just 5 sessions, usually over the course of 1 to 2 weeks. When we condense the treatment this way, we give a higher dosage during each treatment, and we use tools, specifically image-guided monitoring, to make sure that we're giving the radiation treatment as precisely as possible. Now, why are we doing this? There are a few reasons. One is that we have actually found that biologically, prostate cancer appears to respond better to radiation treatment when it's given in this way, with higher dosages in fewer treatments, rather than spreading it out over weeks. Secondly, there's an important convenience and cost savings to doing this treatment in a shorter fashion. The experience of going through 9 or 10 weeks of radiation and the disruption to somebody's life is major. And if we can cut that down to just 1 or 2 weeks, that is really important for people, and it just makes the treatment much easier. And then lastly, there is the potential that we could improve the disease control, so the cure rate, and lower the toxicity or the side effects when we do the treatment this way. So the first clinical trial I want to describe is something called the PACE-B trial, and this was a clinical trial that was done in Europe. It was published last year in the New England Journal of Medicine, and this was a randomized trial. Looking at the left here, it's a description of sort of who was treated in this trial, and essentially 874 men with localized prostate cancer were randomized to receive either conventional radiation treatment over the course of 20 to 39 fractions, so sort of 4 to 8 weeks, versus the SBRT treatment in 1 to 2 weeks. And they followed these patients for a median time of 6 years. And what's shown here on the right is the result for the primary endpoint. And so this is a Kaplan-Meier curve. This is a common way of demonstrating findings from oncology clinical trials, where on the x-axis is time. So this is the number of years from when people were treated. And on the y-axis is sort of the proportion of people who had a certain event. And in this case, that event would be a recurrence. And so you can see that over time, these lines go down, meaning some men are developing recurrences over time. But you can see there is really no difference between the blue line and the orange line. And what this has told us is that the stereotactic treatment, in terms of the risk of a recurrence, is not inferior and appears to be essentially equivalent to a conventional radiation treatment. And what's promising is that we're seeing that 95 or 96% of people over the course of 6 years are not developing recurrences. So these are outstanding results that we're seeing with modern radiation treatment for this population of people with prostate cancer. And these are important results. They also looked at side effects. So on the left here, these are GI or bowel side effects out to 5 years. And again, you can see the rates of significant bowel side effects are low in both arms, whether people had conventional or stereotactic treatment. And GU is genitourinary. So these are some of the urinary side effects of treatment. Also, you can see that generally these are low frequency events, but there is actually this signal of between sort of 12 and 18 months, people who got stereotactic radiation may have had a little bit more in the way of urinary symptoms than people who had conventional radiation. Once you start to go out 3, 4, 5 years, there's really no difference. So this is probably a temporary effect, but this has also been reproduced in other studies, and it is real. So what can we take away from this trial? I would say, first of all, prostate SBRT has been shown to be not inferior to conventional radiation in this group of low or favorable intermediate risk patients with prostate cancer. At a median follow-up of 6 years, there are low risks of high-grade toxicity. So the severe side effects that can develop from radiation, they appear to be very rare when treatment is delivered this way. As I mentioned, there might be this temporary increase in urinary symptoms 12 to 18 months after radiation when stereotactic treatment is given. But importantly, as I said, this is a more convenient and much more cost-effective treatment. And this is now really entering the standard of care for delivering prostate radiation for many people. And this is good news for patients everywhere because it's a shorter, more effective, more convenient treatment. And, on an individual level, this is easier for any person going through cancer treatment. But on a societal level and on a larger sort of scale, this is really important because doing shorter treatments requires fewer resources. It's less cost. It allows healthcare facilities to treat more people and do it in a timely way. And it allows this to be disseminated, hopefully throughout the world to benefit more people with shorter treatments. You can imagine going to a center for 1 or 2 weeks for your cancer treatment is much more feasible for many people than taking 2 months to relocate and have cancer treatment every day. I want to move on to describe another trial done by the same group. This one's actually called the PACE-A trial, and this was also recently published. And this was a really interesting clinical trial. It was small, so it was only 123 patients that participated, but people were actually randomized to receive either stereotactic radiation or surgery, 2 very different treatments for prostate cancer. But this is a decision that many men who are faced with a diagnosis of prostate cancer have to make, whether they're going to have radiation or surgery. And importantly, they looked at patient-reported outcomes. So they had all of the patients fill out questionnaires about symptoms or side effects over the course of treatment and in follow-up. And when we look at the different types of questions that these patients answered, first looking at urinary incontinence over time. In red is surgery and in blue is radiation. You see that with surgery, there is this immediate effect of some urinary incontinence that develops. And this is not a surprise. This is one of the known issues with radical prostatectomy. Encouraging it is to see that much of this recovers gradually over time by the time people are 12 or 24 months after surgery. Interestingly, in the radiation group, we didn't really see much in the way of urinary incontinence. What we saw, though, were other issues. For instance, urinary obstruction. So this is the urinary, frequently waking up at night, weaker stream, maybe some discomfort. These are the types of symptoms that are more common with radiation, and we see that borne out in this trial. Similarly, with bowel side effects, having maybe diarrhea or more irregular bowel habits, that's also an effect potentially of radiation that is not as pronounced with surgery. When we look at sexual side effects, that appeared to be more profound in the surgical arm in this trial. And so I think what this is telling us is it's sort of painting us a picture of what we can expect in terms of side effects when we're facing this decision of radiation versus surgery. So it provides some basis for comparison to understand what might happen over the course of the next 12, 24 months if I embark on radiation or surgery. So this is very useful data for us to have when we're thinking about treatment options. So I'll move on now to talk a little bit about new radiation technology, because radiation technology has been evolving very rapidly. And I want to talk first about something called MR-Linac, or MR linear accelerator. And this is essentially a machine that combines an MRI scanner together with a radiation delivery system in the same device. And this can acquire MRI images immediately before and during radiation treatment to more precisely line up our treatments. It allows us to do something very powerful, also called adaptive radiation, which I'll describe, where we can account for day-to-day anatomical changes. And so for the first time, this allows us to actually see while we're treating with radiation, which is really exciting. And so here's an example of this. This is somebody who is receiving, whoops, I wonder if we can play this video. I'm not sure if that's possible, but this is an image of somebody who's receiving prostate radiation, and we are actually able to monitor in real time the position of the prostate and ensure that it's exactly right on target while the radiation is actually being delivered. And in case this video is not playing, what it shows is that we're able to track the prostate even if it moves, and there's a safety mechanism that's built in that if the prostate moves, it turns off the radiation beam automatically. Now there is new evidence to say that this treatment may be beneficial when we compare to prior forms of radiation. And so this was a clinical trial called the Mirage trial done at UCLA, which was a randomized trial of MR-Linac-based prostate SBRT versus standard SBRT, using usually a CT scanner or a cone beam CT. And what they found was a significant reduction in acute urinary side effects from 43% to 24% when using MRI, and a significant reduction in GI or bowel side effects from 10% to 0, grade 2 or higher with MRI guidance. So this is really exciting, showing that the side effects of treatment can be reduced by the precision of the treatment. And then I won't go through all of this, but this is a study that we did, which was something called a meta-analysis, where we actually combined data from 29 different clinical trials that included over 2,500 patients with prostate cancer. And we measured the effect of MRI-guided adaptive treatment versus CT-guided treatment, and how it impacted urinary and bowel side effects, and saw a very similar reduction over the sort of broad spectrum of these 29 different trials that have been conducted. So the conclusion here is that precision radiation using, for example, MRI guidance or adaptive treatment can reduce urinary and bowel side effects, which are two of the most common impacts on quality of life when people have to undergo treatment for prostate cancer. This is just an update of the Mirage trial showing that 2 years later, these findings did hold and that the reduced side effects in terms of urinary and bowel remained reduced even 2 years or 24 months after treatment. Now, I mentioned adaptive radiotherapy, and I sort of want to describe exactly what that means and what we're talking about. What this refers to is daily adjustment of the radiotherapy plan to account for day-to-day anatomical changes while the patient's receiving radiation treatment. And this is allowed and made possible by the fact that the technology condenses the effort of planning a radiation treatment that we're used to taking several hours or even days into just a few minutes while the patient is lying on the table in the machine. And so an example of this graphically, this is an image of somebody's pelvis. And what we're looking at, sort of this cloud here of blue and green, is the area that would be receiving high dose radiation. And this is targeted at the prostate and the seminal vesicles here. And immediately adjacent to the prostate is the bladder and the rectum right behind it. And these are areas we need to avoid when we're delivering radiation. Now, this all looks great, and it looks like everything's right on target. But when somebody comes in on any given day for radiation treatment, their anatomy can look very different. So on this day, when the patient arrived and when we took a scan, we saw that the bladder was actually emptier than it was when we did the planning session. And the rectum was actually more full with some stool and some gas. And this happens. The issue is that if we had delivered our original plan, part of this high dose treatment would have been delivered into the rectum, and we would have actually missed part of the target. And that's not what we want to do. And so, what adaptive treatment allows us to do is make these corrections in real time using the imaging from the patient while they're there receiving the treatment on the radiation table. So, this is sort of real time personalization of the radiation. And the potential advantages here really are that it can reduce side effects. As you can imagine, being more precise and avoiding the rectum and the bladder can allow us better control and reducing radiation of normal organs and tissues, which can lead to side effects. It also might improve cure rates because we're going to be hitting the target more accurately with our treatment. And because we can do that, we may even be able to give higher doses that could be more effective because we know that it's going exactly to where we want, and we're a much lower chance of hitting the sensitive organs around the prostate. So this is really exciting. And I show this slide because anybody who's gone through prostate radiation may be familiar with this starter pack of materials. So this is Gas X that we give people to reduce gas while they're receiving radiation, Miralax to keep people's bowels moving and empty, fleet enemas that we sometimes require people to have to keep the rectum empty. This is a rectal tube that is inserted to eliminate gas from the rectum, drinking water in copious amounts to keep the bladder very full. And this is a rectal spacer that is injected between the prostate and the rectum to separate them and allow us to give radiation more safely. And so this is really asking a lot of our patients and people who are getting prostate radiation. It's a tremendous burden and a huge source of anxiety for people getting radiation to try to get their anatomy just right. And what we're now able to do is, instead of asking our patients to control their anatomy with millimeter precision, we can use technology to work around whatever anatomy somebody shows up with. So this, I think, also is just making things much easier in terms of the day-to-day experience for people getting radiation. We don't have to be nearly as strict about all of these things because we can work around any bladder filling or bowel or rectal filling as well. The last topic I want to discuss is radiation for metastatic disease. So in terms of prostate cancer, this is a spectrum. And the spectrum goes from somebody with localized prostate cancer, just in the prostate, to somebody with widely metastatic and what we call castrate-resistant disease, which means it's become resistant to the hormonal therapies that we use for prostate cancer. Somewhere along this spectrum, there is a phase that we often call oligometastatic disease, where somebody might have a small number of metastases, but they have not progressed to this point of becoming widely metastatic. And the question many of us have been asking in this field over the last several years is, can radiotherapy help people here when we see just these first signs of the cancer spreading outside of the prostate? And many trials have been done now asking this question. And I want to just show one study that was presented a few months ago at GU ASCO. And this was a meta-analysis again, combining data from 5 different randomized trials looking at oligometastatic prostate cancer, where the cancer has spread to less than 5 areas in the body. And people were randomized in these trials to receive either radiation to the spots anywhere in the body where the cancer had spread versus the standard of care treatment, which is usually hormonal therapy. And what was found when you combine all of these studies is that progression-free survival is significantly improved when we give radiation to areas of metastatic disease. The other interesting finding here is that they looked at something called freedom from castration resistance. In other words, were these treatments able to prevent men or slow down the time from developing castration resistance, which is a much more difficult to treat phase of metastatic prostate cancer? And the answer was yes. We did see that with radiation, metastasis-directed radiation seemed to slow down the time to development of castration resistance, which is really important. And then 2 other trials recently have looked at not just treating the areas of metastasis where the cancer has spread, but treating the prostate itself after the cancer has already spread outside of the prostate. And this is interesting because in our field, usually we have the classical teaching has been, once the cancer spread outside of the prostate, there's really no point in doing treatment to either irradiate or remove the prostate because the cat is already out of the bag, the horse is out of the barn. What's the point? We just introduce risk. But what these studies have found is that in people with a low burden of metastatic cancer, radiation to the prostate actually improves survival. And it also does something to prevent complications. And this is important because a cancer that grows in the prostate can cause serious problems. It can lead to pain. It can lead to bleeding. It can lead to blockages that require a catheter. And what was found in the PEACE 1 trial is that these serious problems can sometimes be prevented by giving radiation early on when somebody has metastatic cancer. And so this is all to say that the role of radiation treatment in metastatic prostate cancer is really coming a long way, and we're finding sort of unexpected benefits to doing radiation treatments we weren't even considering a few years ago. And so in conclusion, to summarize, radiation therapy for prostate cancer, like I said, has come a long way in just the last few years. The treatments are generally getting shorter, less taxing for people, and more effective. And a lot of this is related to technology that's reducing side effects and making it easier. For people with metastatic prostate cancer, radiotherapy is proving to have an important role. And what I would end by saying is that because we're seeing radiation becoming increasingly important, I really think anybody who's diagnosed with prostate cancer, whether it's localized or metastatic, should really consider speaking with a radiation oncologist, because you may be surprised. You may learn about options that you didn't know otherwise were available. And it's good to have that information so that you can make an informed decision and receive the best treatment. So I will stop there, and I thank everyone for attending. Thank you for your time, and I'm happy to take any questions.
Awesome. Thank you so much, Dr. Leeman, for such a great presentation. I know we are coming close to time, but I think I can maybe get a question, maybe 2, depending, answered. But for everyone who's on this session right now, just a friendly reminder, right after this session, Dr. Leeman is actually going to be participating in a roundtable with us. So if you have any further questions, you can come join our roundtable there, and we can hopefully get some more of your questions answered. So one question that came in is brachytherapy radiation often recommended, and what alternatives exist?
Right. That's a good question. So brachytherapy is a type of radiation therapy where the treatment is given internally, sometimes by implanting radioactive seeds directly into the prostate, or by putting catheters into the prostate and delivering a radioactive source to different areas. And this has been shown to be a very effective treatment for prostate cancer. And this is part of the discussion, because there are now so many radiation options available, it's about finding the right one for any given individual. And that's why the discussion with the radiation oncologist is so important. There may be situations where brachytherapy is appropriate. There may be situations where it's not the right treatment for you, depending on the size of your prostate, the stage, any symptoms you have at the outset. And now there are actually also situations where we're doing a combined approach of brachytherapy and external beam radiation with higher risk cancers. And so brachytherapy is certainly important, and it's a mainstay of prostate radiation, but it's an individualized discussion about what is going to be best for you, whether it's brachytherapy or external beam treatment or a combination.
Perfect. So I don't want to cut us short, but unfortunately we are really close to the end, and I don't want anyone to be late for the next sessions. We did get quite a bit of questions, so if you come to our roundtable, which you should right after, if you're interested in learning more about radiation, please come. I can bring some of the questions that were asked from this session over there as well. But thank you, everybody.